friends, today we'll discuss AIIMS November 2019 anesthesia questions, and this time you could see that there are at least 10-11 questions in anesthesia, and particularly the questions were more on CPR or resuscitation. So that really is becoming very important. Now the focus is more on clinical side, practical side. So let's start with the first question. Regarding CPR, choice A can be given irrespective of the rib fracture. Of course, it doesn't make difference whether there is rib fracture or not. Yeah, CPR means you have to give CPR, and it doesn't make difference whether there is rib fracture or not, because chest compression is not given over precordium. Although I have seen even senior people doing this mistake, that they are doing compression over precordium. So their success is only judged by how many ribs they have broken. So chest compression is done over the lower third of sternum. So chest compression is given over lower 1/3 of sternum. So can be given irrespective of the rib fracture. True. Adult chest compression and ventilation ratio is 30:2 with 2 resuscitators. Now ratio actually depends on the situation, whether you are doing CPR with advanced airway or without advanced airway. With advanced airway means you have already intubated the patient, and without advanced airway means you are doing CPR with bag and mask ventilation. So compression to ventilation ratio for infants, children and adults. Without advanced airway, and with advanced airway. So without advanced airway, if you are a single resuscitator, then ratio is 30:2 for all ages. Means you will be giving 30 compressions, go to mouth, give 2 successive breaths, come to chest, give 30 compressions, go to mouth, give 2 rescue breaths. But if you are 2 resuscitators, then this ratio will become 15:2 for infants and children, while for adults it will still remain 30:2. So you can say compression ratio for adults is 30:2 irrespective of the number of resuscitators, while for infants and children, single rescuer 30:2, more than one rescuer 15:2. But once you have achieved the definite airway, means once you have intubated the patient, then all these ratios finishes. Then for all age groups, one person will continue compressions at a rate of 100 compressions per minute with 10 breaths per minute without synchronization. You know that before 2010, our CPR method used to be 5 compressions, then give 1 breath, 5 compressions, then give 1 breath. So with that method, they found that more than 30% of the time is getting wasted in this synchronization. So now they say one person will continue compression at a rate of 100 compressions per minute, and second person will give breath after every 6 seconds by watch. Means 10 breaths per minute, and the person giving compression will not stop at the time when the person is giving breath. That means your cardiac massage must be uninterrupted. So that is, you can say, is the cardiac massage must be uninterrupted. So you can say the crux of cardiac massage is that it must not be uninterrupted even by the breath. So cardiac massage should be continuous, uninterrupted. Now we can look at the questions, choices. So adult chest compression and ventilation ratio is 30:2 with 2 rescuers, true. Compression rate is 100 to 120. Yes, I told you actually compression rate is 100, but 2015 they said yes, 100 is okay, but it should not be more than 120. So 2015 guideline says compression rate should not be more than 120. 100 is okay, but should not be more than 120, means you should not be very fast. That is 2015 guideline. So that is also true. Compression rate should be kept between 100 and 120. 100 is minimum, maximum is 120. AED if available, give compression and shock every 3 minutes. AED means automatic external defibrillators. Actually giving shock, they found that even if the patient recover after cardiac arrest, it take minimum 2 minutes for the heart to attain the normal cardiac output. So those 2 minutes should be considered as a period of cardiac arrest. So during those 2 minutes you have to give compression even if the rhythm is sinus. So therefore they say after giving defibrillation, after giving shock, you will not be checking the rhythm. You will be just continuing CPR for 2 minutes. Then only you check the rhythm, and only after checking the rhythm, obviously if you find rhythm to be shockable, then only you will be giving neck shock. And now you know that all shocks are of 360 joules. So what we do, just I'm summarizing. So first thing what we do is we give plain shock, and I told you all shocks will be of 360 joules if you are using monophasic, and if you are your biphasic defibrillators, then it will be 150 to 200. So you give shock, and after giving shock you continue CPR for 2 minutes and then check rhythm. And if rhythm is still shockable, then your next step would be to inject adrenaline plus shock. Then again continue CPR for 2 minutes and then check rhythm, still say the rhythm is shockable. Then our next step would be to inject second dose of adrenaline plus shock. Still again you will continue CPR for 2 minutes, and now they say rhythm is still shockable. Then your next step would be to inject amiodarone. If amiodarone not available, then you can use lignocaine plus shock, and again continue CPR for 2 minutes, and if the still rhythm remains shockable, then go to step number 2, not step number 1. So now you can look at the choice. They says AED if available, give compression and shock every 3 minutes. No, there is no that we will be giving shock after every 3 minutes. We will continue CPR for 2 minutes and then only we will give shock. So that becomes false. For infants Compression and ventilation ratio is 30:2 with 2 rescuers. False. I told you for infants and children, compression and ventilation ratio is 15:2 if you are 2 rescuers. Steps of intubation sequence. Now generally what we think that if I ask you what should be the position of neck during laryngoscopy or intubation, your reflex answer would be extension, and that is actually the mistake I have seen people making. When they intubate, they extend the neck. So if you will extend the neck, larynx will become more anterior and intubation becomes more difficult. So actually we have to achieve extension at atlanto-occipital joint and flexion at cervical spine. So that is the optimal or ideal position for intubation, and this position is also called as morning sniffing position. So you have to achieve extension at atlanto-occipital joint and flexion at cervical spine, and this can be achieved by simply placing a 6 to 8 centimeter pillow, or you can say a ring or a folded towel below the occiput. Automatically will achieve this position. Then once you have achieved this position, you are satisfied with the position. Then if you are a right-handed person, then you will be holding the laryngoscope in left hand and you will start entering from the right angle of the mouth. Keep on going downwards, displacing the tongue anteriorly till you see the epiglottis. Once you see the epiglottis, then you can anteriorly displace the epiglottis in case of adults, while in infants or smaller children, epiglottis is large and leafy and anterior is larynx is very anterior and upwards placed also. So we have to actually lift that epiglottis, but in adults just pushing the epiglottis anteriorly may be sufficient. Once you push the epiglottis anteriorly, then you will be able to see the vocal cords, and once you see the vocal cords, then only you should attempt intubation. I've seen really people doing this mistake, causing a lot of trauma. They are not seeing the vocal cords and try to intubate. So if you're not able to see, that means you are making some mistake in position, or patient thyromental distance may not be okay, or patient may be difficult case. So you have to see what mistake you are making rather than blindly attempting. You can't attempt blindly, you should not attempt blindly. So be able to see the vocal cords and then only place your endotracheal tube. Once the tube is in place, inflate the cuff with the air, and normally 5 to 6 ml air is sufficient, but it's not the volume that is important. Important is the pressure. Cuff pressure must not exceed about 25, otherwise there is increased chance of tracheal ischemia or tracheal injury. Once cuff is inflated, you start ventilating the patient and then confirm the position of this endotracheal tube by capnography. If you don't have capnograph, then you can use auscultation or look at the chest expansion. So now we can look at the sequence of intubation. First thing is okay. First we'll achieve the position which I told you, extension at atlanto-occipital joint and flexion cervical spine. Then you will introduce, so this should be the first step, and then you will introduce laryngoscope from right side of the mouth. Yes, correct. So once you see the vocal cords, then you put your tube and then you inflate the cuff of the endotracheal tube, and then you will confirm the position of your endotracheal tube. So first should be A, second should be C, 3 in fact, then B, and then D. So it should be D actually. So in place of A, B, C, D, like you can say 1, then will be 3, then will be 2, and then will be 4. So D is most appropriate. D. False statement about the following image. What is this? This is automatic external defibrillator, that is AED. Automatic external defibrillator, and these are the pads which will be placing over the patient chest. And since this AED is for the common man, so they have clearly make, you can see the diagram, so that by looking at the diagram you can know that this is a precordial. You can see that this is a precordial pad, so it will be placed over precordium, and this is a sternal pad, so it will be placed right infraclavicular. So diagram is also there. Then this is a AED, and this is a bag which contains this AED, and these are the batteries. So AED, you know, is the automatic external defibrillator. Automatic external defibrillator means, as the name suggests, means you have to simply switch them on, place over the patient chest, automatically it will diagnose the rhythm, and if the rhythm is shockable, then it will select the energy and deliver the shock. So it can be used even by common man. So basically this automatic external defibrillators are the part of basic life support, while manual defibrillators which we are using in our hospitals, there you have to diagnose the rhythm, you have to select the energy, you have to charge, and you have to give shock. So manual defibrillators can only be used by medical personnel in hospital setup, so they are the part of advanced life support, while AED, automatic external defibrillators, are meant for common people, so they are the part of basic life support. And since they are meant for common men, so they are also called as public access defibrillators. So now they have changed the name of AED to PAD. So now AED are called as public access defibrillator, and in West you go everywhere you will find this AED or PAD at airport, railway stations, metro, markets, subways, you will find. India, you also happen to see them in on airport. Some boxes are there, something inside is there, I don't know, but yes, at least boxes are there. So it is the part of advanced life support? No, false. It's a part of basic life support. It only delivers a shock of 300 joules. Actually 300 joules is no shock nowadays. All shocks are of 360 joules, I told you. If it is monophasic, if it is biphasic, then it will be 150 to 200. So that's also wrong. One pad is applied over precardia, another over sternum. No. Again false. It is, I told you, one over precordium, and another one pad it is written apex. So apex pad is over precordium, over apex. Another pad it is written sternal, but sternal pad does not mean that it will be placed over sternum. Sternal pad is placed over right infraclavicular. So false. It is used for medical personnel only. False. So actually all of the above is. All are false. All of the above statements are false. A patient with supraventricular tachycardia became unconscious. Supraventricular tachycardia, unstable ventricular tachycardia. Unstable ventricular tachycardia means pulseless ventricular tachycardia or polymorphic ventricular tachycardia, you know, we have to defibrillate. But for supraventricular tachycardia, we need not defibrillate, we just need to go for cardioversion. Although for stable supraventricular tachycardia, you can use medications, adenosine, or you can use amiodarone. But similarly, for stable ventricular tachycardia, you can use amiodarone, but unstable ventricular tachycardia defibrillation and unstable supraventricular tachycardia, we have to go for immediate cardioversion. A patient was on epidural for post-op analgesia on a dose of 3 milligram morphine per day. Okay. However, by mistake one day accidentally 12 milligram morphine was injected through epidural catheter, which statement is not correct. So normally we actually do not prefer morphine much for epidural because morphine causes delayed respiratory depression. And why morphine causes delayed respiratory depression? Because morphine is poor lipid soluble. What is the mechanism action of epidural opioids? Because epidural route is very frequently utilized for opioids. Opioids are most, you can say, most preferred through epidural route. And what is the mechanism of action? These epidural opioids, we deposit them in epidural space, but you know that opioid receptors are present in spinal cord, substantia gelatinosa of spinal cord. So they need to cross these meninges to reach the spinal cord. And morphine, you know, is a poorly lipid soluble drug, so it will cross meninges very slowly. So it will remain in contact with CSF for prolonged periods. So it will mix with the CSF, and along with the CSF in the next cycle of reabsorption, it will directly reach brain to inhibit the medullary centers, producing delayed respiratory depression. Now it takes few hours, slowly it will absorb, then it will get accumulated in CSF, and then in the next cycle of CSF it will reach medullary centers to inhibit them. It takes few hours, so it is called as delayed respiratory depression. Other opioids, that is fentanyl, L-fentanyl, they are highly lipid soluble, so they cross meninges so rapidly that they don't get time to accumulate in CSF, so they won't produce respiratory depression. So delayed respiratory depression is one of the major problem for which we generally avoid morphine, but yes, still some people they use morphine. So mostly we are actually using fentanyl. As an infusion, actually, as a continuous infusion. So means dose has become very high. Instead of 3 to 12 milligram, 4 times. Actually this is disastrous, honestly speaking, very disastrous. This is going to produce so severe respiratory depression that it can become really an emergency. So patient will, which is not correct, okay. Patient will complain of itching, true. One of the side effect of opioids is itching, that we know. Supplement oxygen by mask may be required, not may be required, actually it will be mandatorily required. This patient may require even ventilation also, but definitely oxygenation will definitely be required. This patient is going to have respiratory depression. Patient will have urinary retention, yes. One of the major problem of epidural opioids is urinary retention. They can cause significant urinary retention. Patient will complain of numbness in limbs, no. See, they do not act on motor function. Motor inhibition, motor paralysis is only seen with local anesthetics. That is actually there are two main, you can say, advantages of opioids. There are two main advantages of epidural opioids over local anesthetics. Advantages of opioids. Over local anesthetics. One, no hypotension. Local anesthetics, you know, they block sympathetic chain leading to venodilation, decreased venous return, and hypotension. Local anesthetics can cause significant hypotension. You see significant hypotension after spinal anesthesia or epidural anesthesia. And secondly, no motor paralysis. Because opioids do not act on spinal nerves, while local anesthetics act on spinal nerves, leading to motor paralysis. Disadvantage only we have seen is possibility of major possibility of respiratory depression. Then another disadvantage I told you is urinary retention, actually quite common. So motor paralysis will not be seen with opioids. Patient will not complain of numbness. The following 4 items consist of 2 statements, one labeled as assertion and other labeled as reason. You have to examine the 2 statements and decide if assertion A are individually true, and if so, whether the reason is a correct explanation of assertion. Select your answers to these items using the codes given below. The mark your answer sheet accordingly. Assertion: for airway management, flexion of neck is required, and the reason jaw thrust prevent tongue falling back on posterior pharyngeal wall. For airway management, again, don't get confused with intubation. For airway management, you know that the manual method of airway management is triple maneuver. And actually airway management means, what is the most common cause of airway obstruction? Tongue falling back on posterior pharyngeal wall. So airway management, you can say, to begin with, A means you are preventing tongue falling back on posterior pharyngeal wall, or you can say you are preventing the obstruction of airway by tongue. So manual method of managing it is triple maneuver, which is chin lift, head tilt, and jaw thrust. Head tilt means neck extension. Head tilt means neck extension, and this chin lift and head tilt is done as a single maneuver. Means when you lift the chin, automatically there will be extension of the neck, and jaw thrust means anterior displacement of the mandible, and I told you this is done to prevent the tongue fall. But in a hospital setup you have much better methods, and the simplest method of managing airway is by Gudel's airway. Udal airway. However, we always assess breathing and airway simultaneously, because if breathing is absent, you will be intubating the patient. So endotracheal tube will take care of airway as well as breathing. But if breathing is present, then putting Gudel's airway may be sufficient. Now just one more thing I like to tell you before going for the question. If you are expecting cervical spine fracture, will you go for head tilt chin lift? No. It should preferably managed by only jaw thrust. However, if not, then you can go for head tilt and chin lift, and that does make a sense, because if you will not be able to manage airway, the patient is going to die. Then what will you say by saving the cervical spine of a dead body, which actually may not be there? You are just suspecting, you are not confirmed. So obviously life is a priority over the cervical spine. So you have to manage life. Cervical spine we can see later. So now we can look at the question. For airway management, flexion of neck is required. This is false. Wrong statement. Jaw thrust prevent tongue falling back on posterior pharyngeal. This is true. Now we can look at the choices. Both A and R are true. For rule out. Both A and R are true. Again rule out. A is true, but R is false. Wrong. D, A is false and R is true. So D, yes. In addition to acting on opioid receptors, Tramadol also produces analgesia. So Tramadol is an opioid, and you can say disadvantage and advantage both, that the major problem of Tramadol is that Tramadol increases serotonin levels by preventing reuptake of serotonin and also by releasing serotonin, and moreover it also prevents the reuptake of noradrenaline. So the beneficial effect is that it increases the level of serotonin and norepinephrine also, and serotonin itself has got analgesic property, and this increased norepinephrine can act on spinal modulation of pain. You know, even serotonin can also act on spinal modulation of the pain to increase the analgesic effect of Tramadol. And another advantage is serotonin, you know, is antidepressant. So Tramadol is actually very useful for chronic pain, because in chronic pain, you know, chronic pain is almost always associated with depression. So serotonin is very beneficial. So this combination of paracetamol plus tramadol, Ultrasat, is commonly prescribed drug. However, there are now certain regulation about it also. But acute pain, India, you will see it to be commonly used. However, in acute pain, this increase in serotonin becomes the disadvantage, because increased serotonin will increase the level of you can say increased serotonin can cause hypotension, nausea, vomiting, flushing. So that is why Tramadol is more preferred for chronic pain. However, I told you that it is still commonly used for analgesia in acute situations also, post-op pain. So now we can look at the question. In addition to acting on opioid receptor, Tramadol also produces analgesia by D, blocking reuptake of serotonin and norepinephrine, particularly serotonin. A soldier was brought from Siachen suffering from hypothermia. Which of the following temperature closely reflects core temperature? Yes, this is important. Actually, regarding core body side temperatures, you will see lot of confusion not only in your guides or MCQ books, even in your standard textbooks also. And the reason I'll tell you. For core temperature measurement, the most accurate site is the pulmonary artery. However, it is not possible to calculate pulmonary artery. Cost wise, the Schwann-Ganz catheter, pulmonary artery catheter, cost to 10,000 rupees. The monitor working with Schwann-Ganz catheter are highly sophisticated, costing 2.5 lakh, 3 lakh rupees. So just can't spend 3 lakh rupees for temperature monitoring. Moreover, life-threatening complications can happen with the pulmonary artery catheterization, including pulmonary artery rupture, pneumothorax, pneumomediastinum, hemomediastinum. So you obviously cannot subject the patient to such dangerous complications just for temperature measurement. Then technically it is difficult, you require expertise, very time consuming. So considering all these factors together, you can say that most commonly used, or you can say the best. To say something best, you have to look all factors, technical feasibility, cost, complication. So considering all these factors, you can say the best site for measuring core body temperature is lower end of esophagus. The probes are just like Ryle's tube. They are just placed in the lower esophagus and connected to any of a routine monitor. Now sometimes we don't need a whole body temperature, we just need brain temperature. Again, the most accurate site for brain temperature measurement is tympanic membrane. However, there has been case reports of tympanic membrane perforation. There has been case reports of tympanic membrane perforation. So obviously you cannot perforate tympanic membrane for temperature measurement. Therefore you can say that the most commonly used or best for brain temperature measurement is nasopharynx. The probe which you have placed in esophagus can be placed in nasopharynx. Now you can see the question. So the best for core body temperature is esophagus, because core body temperature actually is higher than peripheral temperature, which is particularly anesthesia. Why don't we rely on peripheral temperature like skin or oral cavity? Because you know that all anesthetic agents, they are vasodilators, so they lead to heat loss, and so that will divert heat from core part to the peripheries. So core temperature may be normal, peripheral temperature may be normal, but patient may have significant hypothermia. So temperature should best be measured by core temperature. Peripheral is not that reliable. Post-operative pulmonary complications are seen in all of the following except. Actually, post-op complications depends on number of the factors, like patient factors. So the risk factor for post-op pulmonary complications, patient factors are age more than 60 years, ASA more than grade 2, then heavy smoker, then having pulmonary disease, and particularly dyspnea at minimal activity. Then obese. And why obese patients are at risk? Obviously because they have restrictive, if you do their pulmonary function test, they will have extra parenchymal restrictive pattern. Then surgical factors, is site. Site means this upper abdomen or thoracic surgery or upper abdominal surgeries. Then whether surgery is major or minor, so obviously major surgery. Duration more than 3 hours. So these are some of the factors, and among these most important, if you ask me, that the most important risk factor is dyspnea at minimal activity, and surgical most important risk factor is thoracic surgery or upper abdominal surgery. So if these are the factors, definitely the patient is more vulnerable to have post-op complications. So now we can look, yes, obesity, BMI, post-operative complications seen in all of the following except, yes. Yes, it's little tricky. Obesity is there, obese, but actually you can say morbidly obese. So in these choices, BMI more than 30 is obesity but not morbidly obese, so that appears to be the best choice, because upper abdominal surgery, very important factor. Patient with 7 pack years of smoking, yes, it is there, and old age more than 70 years. The role of glycopyrrolate in premedication. Glycopyrrolate or atropine, they are used to decrease the secretions. They are used to decrease the oral or tracheobronchial secretion. However, the routine use of these drugs is not advisable. Actually, there is no word like routine premedication. No premedication is given as routinely. There has to be clear-cut indication. Similarly, this anti-secretory drugs will be given if there is a clear-cut indication. For example, say oral surgery, where dry mouth is the requirement, or if you are using an agent like say ketamine, which increases the tracheobronchial secretions, we will be giving. And if you decide to give among these, then definitely the preferred is glycopyrrolate. So glycopyrrolate is preferred over atropine. Why? Because glycopyrrolate do not cross blood-brain barrier. It's a quaternary compound, so no CNS side effects. So that is the main reason for preferring glycopyrrolate over atropine. Otherwise, atropine can cause central anticholinergic syndrome. Then there was one more question which by chance has not been there, and they had asked that which test we perform before cannulating radial artery for invasive blood pressure monitoring and ABG analysis. So which test is performed? Before cannulating radial artery. And you know that we cannulate radial artery for invasive blood pressure monitoring, and or for getting samples for blood gas analysis, ABG. So before cannulating radial artery, we have to see the patency of ulnar artery, because now circulation will be maintained through ulnar artery, and the test that we done, you all know, is called as AIIMS test, which I think all of you would have done in your surgical postings. So it's a simple test. What we do, we completely exsanguate the hand, and after complete exsanguation, now we occlude both radial and ulnar artery. Now release pressure from ulnar artery while maintaining pressure on radial artery. Now color of hand if returns to normal within 7 seconds, that means ulnar circulation was patent, so you can easily cannulate the radial artery. So AIIMS test is done. Now sometimes if you want to cannulate ulnar artery, then we have to see the patency of radial artery. So same test we will perform. The only difference will be that instead of releasing pressure to radial artery, this time we will maintain pressure on ulnar artery and release the pressure from radial artery. Again, if color of hand returns to normal within 7 seconds, means your radial artery circulation is compatible. We can go ahead with the radial ulnar artery cannulation, and that is called as a reverse AIIMS test. So you can say AIIMS test is done to see the patency of ulnar artery, while reverse AIIMS test is done to see the patency of radial artery. And if you find that you can't cannulate ulnar artery or radial artery, means both tests have failed, then what is the second best choice for cannulating artery? Second best artery is dorsalis pedis. Why? Actually, artery should be as peripheral as possible, so that by chance there occurs some ischemia, the damage should be minimal. So artery should be as peripheral as possible. That is why we prefer peripheral arteries, radial ulnar, or if that is not feasible, then we go for again peripheral artery, that is dorsalis pedis. So I think that should be all about. These are the questions which we could find. Any other question if you encounter, you can definitely send them, and then I'll try to give answer to that question as early as possible.